Good afternoon, all. Happy welcome to the foundation course in palliative nursing session 2. Today we are going to discuss about introduction to pain, and we have with us Dr. Radha Venkatesan madam as a faculty and Dr. Shiba madam as facilitator. Over to you, Shiba madam, for more facilitation and introduction about faculty.
Thank you. Very good afternoon to all. As um, you hear today, we are going to learn about introduction to pain. So I hope you all remember the palliative care concept which we have learned last week. So today, the faculty will be here to teach introduction to pain. Dr. Radha Venkatesh, I think most of you all know her. Ma'am, welcome back and over to you.
Thank you very much, Shiba. As we have said, warm welcome back to all of you, because slowly we are getting into the grips of it. First day, you all had an insight and knowledge on what is palliative care. Next, what is going to be the most important or the most common thing that your patients will be coming to you with? Pain is said to be comprising at least 60 to 80% of the main symptom with which most of your patients will be coming. This is what we saw in the introduction to palliative care session also. Why is it important that we need to know? So today, in the next 30 to 40 minutes, what we are going to see is what is that all of you need to know about pain. Okay, next slide. Coming to know what is pain, we need to know what is actually the definition. There is an association called the International Association for Study of Pain, which is the body which gives the definition. And initially in 1979, they had given a definition. And recently in July of 2020, they did very fine tuning or very, very minimal changes to the original definition itself. And that was just not done very casually. They took 2 years, went into many aspects of it, and they had an international body working on it to decide the definition. Based on that, what is seen on the screen is the latest definition given in 2022 July by the same IASP. What it says is, I've mainly highlighted the important word. It is a big definition, but some of the points which are highlighted there are very essential. So every word means. So by definition, it is an unpleasant sensory and emotional experience associated with what? It could be either a actual or a potential tissue damage. And it is also expanded upon by adding 6 important keynotes, which we will see. The important highlighted words are, it is unpleasant. Is pain pleasant any time? Is anyone happy when someone has pain? No. So it's an unpleasant and not only a sensory experience. For example, prick, injury or heat, it's an uncomfortable sensory, it's a sensory element, but there is also an emotional experience, which, as I said, how did I start telling? No one is happy in pain. So that happy, sad is the emotional element in it. And next thing is that actual or potential tissue damage is something we have to keep in mind. Actual tissue damage is what we know when there is a cut or an injury. Potential tissue damage is the important element to be taken here. So there need not be a physical cut, but there could be many other situations where that could be the cause for pain. As we go through the rest of the material that we are going to see, we will read or know more about what is potential damage. Basically, I'll just give a clue here. As I said, there need not be a physical cut. Sometimes, common example that we say is, all of you know about surgery. When someone has surgery, there need not be a cut. We do retraction, many structures are pulled and moved. Even that can cause damage to the nerves. So like that is what is meant as potential. Potential means there is no exact physical damage, but there is damage in some other form. Okay. And the next slide will give the more added on 6 features. Next slide. So what are the 6 important keynotes that were added? First, pain is a personal experience. What I feel may not be the same what another person feels. Each one of us have a different threshold. So this personal experience will have biosocial, physical, psychological, all elements. So everyone doesn't have the same personality, doesn't have the same threshold, doesn't have the same tolerance. So all that also have to be kept in mind. Next, there is difference between pain and nociception. Basically, what is meant here, when someone, by nociception, what is meant is the what happens in our nervous system when pain is perceived. Conduction from one point to the other, that is nociception, which is done by the nerves. Whereas pain, by definition, what we saw, it has sensory, emotional, and higher brain function elements also. That is the main difference between pain and nociception, which needs to be understood properly. Next, patient's expression of pain is to be respected. What does that mean? For example, pain is a subjective phenomenon. For example, a person is experiencing pain, another person cannot feel it. So, we should not belittle or consider somebody else's expression very lightly. If someone says, I am in severe pain, you have to believe, respect, and see how am I going to manage it. So, don't ignore and neglect. That is what is mainly meant here. Next, life experiences do have a role. For example, when someone has an injury or something like that, at that point of time, what were the other life experiences happening for them does have a role in the presentation of pain. For example, someone has pain and at the same time they have a major incident in their life, in their personal life, or their family, or their work, or something like that. There will be a connection or relationship to the pain and the emotion. So that is why life experiences do have a role. And next is, generally pain is said as a symptom. For a very good example for this is, most of us are aware that, for example, right iliac fossa pain. What would we say generally? Anyone wants to unmute and say? Or you can even type. What happens when someone has pain in the right iliac fossa? What is a common thing that you would think about?
Appendicitis.
Very good. So there, how are we connecting the pain and the problem? So normally pain is considered as a symptom to help in the diagnosis. But if the pain persists for long, and then that itself can become a disease. So when pain is there for like 6 months, 3 months, 10 months, something like that, then that pain itself is a disease. It's not a symptom which is helping in the diagnosis. So that is what is mentioned there. Usually is said to be a symptom, but can become a problem by itself too. We'll see about that also in due course. Last one. Verbal expression is one of the mode of expressing pain. Is verbal expression the only mode? If someone can't speak, then can they not express pain? Can they or can they not? Yes, yes, exactly. We have patients in intensive care. They have tubes, intubated. Do they not express pain? Yes, they do. For that, there are very many ways of finding out whether they are in pain. You have just base heart rate, blood pressure, everything will increase. And many times they may have tears in their eyes, Or even patients, we do ask them, if you are in pain, squeeze my hand, they will do. So verbal expression is one of the mode of expressing. So there are other ways of expression too. So that also has to be kept in mind. So these 6 points are quite important, and we have to give importance to all the 6 of them. So especially, as I said, no, we cannot neglect. We have to give due respect and make sure that they also understand it. So these 6 points are very important whenever you consider. If you have all this in mind, whenever you deal with someone who is having pain, it will be helpful for them and for us. Is there anything? Ask him if Dattatreya, do you want to say something? You've got your hand raised.
Do you wish to say something, Dattatreya? Jagre. Oh my God. Thank you.
Okay. Okay, next slide. What you're seeing now on the screen is a diagrammatic representation of what is a pain pathway. So basically, you have, can I have the mouse? Okay. So if you see in this screen, you can see my pointer. See, very free, you have the, where you have the stimulus. It could be a prick, heat, anything. So that is the nociceptive information. That will vary from point to point. For example, if it is in the skin, it may be touch temperature. If it is in the joint, it will be the mechano-stretch receptor. So if it is in the viscera, it will be again distension. So like that, each area will have different types of stimulus. But from the stimulus, what happens next? Next, if you see, there are primary sensory neurons which will have, and then they have many chemical mediators. Either the chemical mediators may be directly, or basically the arachidonic acid will get metabolized to release the chemical mediators. So at the point of injury, lot of chemical mediators are released, and based on this stimulus, it could either be some amount of release, or it could be an exaggerated release of more chemical mediators. All these happen at the site of injury. Okay. So, and then that is called as an inflammatory soup. And that could be directly at the site because of the injury, and also because of other mechanisms also. As I said, one is arachidonic acid metabolism, or this adjacent sympathetic, motor, sensory stimulus, motor nerves besides also can get stimulated. So like that, the one response or one stimulus can be exaggerated even by the chemical mediators. And then you have the primary afferent, which takes it to the dorsal horn. Where am I? Lost my cursor. It goes to the spinal cord. You have the dorsal horn, and from there, crossover happens, and then you have the ascending pathway to the brain, thalamus, amygdala, everywhere it has interconnections. And then you have the descending pathway. The descending pathway basically is an inhibitory pathway. Okay, and then you have the efferent. So this is what is called as the arc or a completion of circle. Basically, this one I just took you all through for you to know. Okay, this is a very basic pain pathway for you to be aware, because you need to know this in future also. For example, for pain itself, you will have few sessions, because you need to know the various aspects. Today, we are just going to see the introduction. Then you have some element of management, like pharmacological, non-pharmacological, everything will be done. But for all of that, this one will be very handy to know this pain pathway. Because first, as I said, how it works. And then where are your medicines going to work? How are they going to work? So everything matters. So this is a basic information for you to know to enhance all the information that you're going to get about pain based on this. Next slide. So what is the significance? It is a multidimensional and complex phenomenon. So as I said, it is just not transmission alone. So you need to comprehend and understand and also assess it properly. For what? To have an effective management. Only if you know what is happening, where all it is happening, then you know how much of impact it has got, then you can manage properly. So hence a good knowledge is essential. So that's why you need to know about what and why is the pain like this. Okay, next slide. So coming to the pathophysiology, we saw the pathway, but why and what is it different, making it so important and more difficult to manage? Is pain something easy to manage? See, for example, take back pain. Someone has injury once, but they have pain lifelong. That is a very good common example for chronic pain. So it is something which needs to be understood well and managed appropriately. So for that, why is it important? Means these give you the reason for it. How when the mechanism by which the damage happens in the body is perceived as a painful thing by the brain, why and how it happens is a complex one. What is the complexity? It is said it doesn't work like a hardwired system, but exhibits plasticity and enables it to modify its function under different conditions. What does that mean? What is hardwire? Hardwire means it has only one pathway. Okay, so I give a simple example. 10 years ago, internet, we all had only wired connection. Okay, from the wall to your laptop, only one connection, so only one route was there. Today, you all only know Wi-Fi, you don't know hardwire connection, isn't it? So, simple example, you can take that because if it is hardwired means, as I said, as I showed you the pathway, it can take only one pathway and do. Whereas in actual reality, what happens is, as I said, the inflammatory mediators, the chemical mediators itself can increase. They need not be small quantity. That is one example. Next is the whole pathway that you saw, everywhere they can be something called as ectopic. That means what? What is ectopic? We all know about ectopic heartbeat and things. Other than the normal area where there should be a response, there can be a new area where also can start stimulation. So like that, there are ectopic firing. There are spontaneous sympathetic, if it is a sensory injury, sympathetic firing and sympathetic involvement can happen. So the whole, basically the nervous system has motor, sensory, sympathetic. If there is injury in one system, other two systems can also contribute. All these type of things, what we are aware in other systems, like ectopic, we are all aware in the cardiac system. So those features and functions can happen in the nervous system also. Collateral firing, collateral sprouting of extra nerves, spontaneous regeneration, those things can happen in and around the stimulus area. So that is what is said as plasticity. It will modify its function under different conditions. So the common examples, what we say here is, for example, someone has chemotherapy, radiotherapy. They can have neuropathic pain and symptoms. So you may think, why? Chemotherapy, radiotherapy, they're having. So medications can cause stimulation. Radiation can stimulate the surrounding nerves, or this is what is potential damage. So all this is very common. For example, if anyone is practicing in palliative care already, means You would have seen patients. Someone who has chemotherapy or radiotherapy can come up with pain symptoms, which we will see also in the next forthcoming slides. Okay, so basically, important thing to take from here is it is not a fixed response. Oh, from A to B, only one type of response. No, it can, you just read the words, modify its function under different conditions. So that is to be kept in mind. And next is pains generally serves the purpose to prevent tissue damage and protect the body, as we saw for acute appendicitis. But under certain conditions, pain can become maladaptive and persist as chronic pain. Okay, so when pain serves no protective function, but it becomes pathological, that itself is a disease on its own. So that is why chronic pain and pain, nowadays you'll be seeing so many diseases like arthritis, rheumatoid arthritis, they all end up in so much of pain. And for them, the rheumatoid arthritis is the disease, but the main problem is the chronic pain. So that chronic pain has become a disease on its own. So that is what is being conveyed. Next slide. So what I was trying to say, what are the types of modulations that can happen? First type, see, because these are the terms you will see whenever you read about pain. Okay, I will give you an insight on all of this in a simple way. First is peripheral sensitization. A very good example will be what I said, chemical mediators. Normally, if there is an injury, for example, if it's a sensory injury, some prick, only sensory, only prick should be there. But what happens at that site of prick itself, motor, sympathetic. For example, sympathetic is you will have burning sensation, cold, heat. That is sympathetic response. Next, motor, you will have difficulty in lifting your hand or something like that. So even though it started off as a sensory stimulus, because of the maximum number of chemical mediators released there, it can end up in becoming a peripheral sensitization. So that is one of the mechanisms by which pain is modulated to become more intense and severe. Next is central sensitization. What does that mean? Central means from the spinal cord up to the brain and everything. There, we saw dorsal horn. Dorsal horn generally has some threshold for creating pain. That threshold can be lowered. So for normal stimulus, there should not have been a response. If the threshold is lowered, means even for small stimulus, it can result in chronic or long pain. That is what, as I said, one of the common factors seen in back pain. And another type in that is something called as amplification. What is that is when you see mechanisms involved in neuropathic pain, you have wind up mechanism given in there. That is easily explained as amplification. What is amplification? What does the word amplify mean? Anyone can answer. Just an English meaning for amplification. To increase. Exactly. Thank you very much. Basically, to increase. Olden days, you would have heard no amplifier. So basically, what happens? As I said, that meaning it increases. Okay. Small pain or low intensity pain is made as high intensity pain. So that is called as wind up. So in that wind up itself, it could be a short term or a long term. So both can be there. So that is what could be kept in mind. It could be a short term amplification or a long term amplification. Amplification lasting for a few weeks or amplification lasting for a few years. So that is one of the things to be kept in mind. And the neuroplastic changes means it, as I mentioned before, it could trigger new sites called as ectopic firing, or it could enhance collateral, whatever is nearby, also collateral sprouting, they say, or upregulation. That means more sensory input may be given. So all these type of mechanisms can happen. Okay, and the neuroplastic changes can happen in when there is lack of blood flow, trauma, infection, radiotherapy, chemotherapy. They all will come under neuroplastic changes in the central nervous system. As I mentioned there, no, this is common in chemotherapy. When someone has chemotherapy, radiotherapy, they may have many of the neuroplastic changes happening, and that could be one of the reasons they end up in chronic pain. Next slide. Any doubts so far? Anybody wants to ask anything not clear or anything like that until now? Okay, in that case, we'll go on to the next slide. Okay, next what we're going to go on is, what are the types of pain? Okay. See, most of you are aware, no? Like when someone has surgery or injury, that is acute pain. Next is chronic pain, when pain lasts for more than 6 to 12 weeks. More than 4 to 6 weeks and lasts for about three months and more, it will be called as chronic pain. In that chronic pain, as it's mentioned in the screen, common examples are diabetes mellitus, arthritis, tumor growths. All these will come under chronic pain. Next is when pain is generated in deep tissues, joints and things, that is somatic pain. Next is visceral pain, when there is pain in the organs inside our body. So normal is gastrointestinal pain. Next slide. This slide is quite important because these are some of the terms. The previous slide terms mostly you might have heard before. In this current slide, some of the terms you might not have heard before. Neuropathic pain. What is that? It is a pain caused by damage to nerves resulting in increased firing. So basically what we have been talking so far, it is caused by damage. Again, it could be an actual or potential damage. And why is it happening? Because there is increased firing. And next one is allodynia. It is one type of nerve pain. What exactly it means is, it is a painful response to a harmless or non-painful stimulus. Common example is touch. Do we all feel pain for touch generally? Yes, no? Do we generally feel pain on touch?
No.
Very good. So generally, we don't feel pain on touch. But if someone is complaining of pain on touch, then that should be a wake-up call for us. So basically, what happens is many patients will come and tell you, my clothes, when they touch my body or skin, that hurts. You will see patients coming up with this. Normally, they say their clothes, dress, or even, for example, one hand touching the other. For example, if they have some problem in the right elbow, their left hand touching their right elbow accidentally, or when they are going somewhere, just the touch, not even flow of air, they will say. A blow of air can cause pain. Normally, blow of air is very soothing for us. But these are things. Generally, how they say is, my own clothes, when they touch knee, for example, they have some problem in the knee. If their own clothes touch them, they are in pain. And blow of air, these are all normally, they don't cause pain. But these symptoms they come with, and as you all start practicing palliative care, no? Or anyone who sees chronic pain patients would have heard about it. That symptom is called as allodynia. Next one, hyperalgesia. That is exaggerated response to normal stimulus. For example, a pinprick should cause pain of certain intensity. But the same pinprick is causing pain, like severe pain. That is called as hyper. Basically, for a particular response, for a particular stimulus, the response is exaggerated, not even just made more. It is multiple times more. That is called as hyperalgesia. It is basically hyper. We all know these are all medical terms which should make more sense. Hyper means increased, algesia pain. So increased pain for a less painful stimulus. Yeah, and the last one is referred pain. Can anyone give a very common example of referred pain? Most of you will be aware of. Give an example, then we will go in a little bit more detail into it. Any common good example of referred pain? I've given a clue of explanation what it is. Pain felt in an area other than the site of origin.
It can be chest pain in case of gastritis.
Myocardial infarction, what happens? As you said, chest pain, no? If there is chest, like myocardial heart attack, sometimes they may not have pain in the chest. Where can they have pain?
Left hand.
So like that, very common is that nowadays we do so much of laparoscopic surgery. After laparoscopic cholecystectomy, where can someone experience pain commonly? What do we tell them when we discharge them? Where is the potential area they can have pain? Anyone can unmute or type or anything you can do. What do you say?
Legs pain.
Leg?
Yes.
Left pain. I can't hear you.
Leg pain, ma'am.
No, like what I'm trying to ask is if someone has laparoscopic cholecystectomy or any laparoscopic procedure in the abdomen, and when you discharge them, what would you say? Where can they anticipate to have pain? Okay, common shoulder pain.
In that,
Shoulder pain
ma'am,
because
in that case,
your voice is breaking. Can you speak once again?
ma'am, in case of the laparoscopic pain, after the discharge of the patient will pain with abdominal distension at the upper side of the abdomen. The patient will feel the pain.
Where will the pain normally be referred to?
Upper quadrant of the abdomen, upper both quadrants of the abdomen.
Upper part of the abdomen will be the area where there could be gas, and the pain is normally referred to the shoulders. Because air under the diaphragm. So that is phrenic nerve.
Yes, ma'am.
So, basically that is what?
Yes.
You are trying to come to say that exactly where, basically in laparoscopic surgery, what they are doing, they are inflating gas so that
inflating air in the abdomen to see the internal organs.
Exactly. They are inflating to get a better view, and they try to suck out as much as they can. But still, there could be some air under the diaphragm, and they can have pain in the shoulder. So, like this, the shoulder pain is because of air under the diaphragm or gas under the diaphragm. So that is what is to be understood about referred. Exactly. So see, pain, no, there are most of the things everyone knows, but connecting and putting things together is what is important. Very good. Next slide, please. Next. Okay, we learned so much about pain. Next, what we need to do, how are we going to assess it? So, and why is assessment is essential? Why do we need to assess?
To give the appropriate medicine to the patient.
One is medication. Next, no, why do you need to assess at all in the first place? One is
Proper diagnosis.
coming, very good. Proper diagnosis, isn't it? We need to diagnose, then we can treat. Yes, so very good. So proper assessment is essential. Mainly, one is to diagnose and also to know whether whatever you're giving or treating is beneficial. So you have to assess and reassess. Do that. That is something all of us have to practice. And in that, nursing team will play a very, very big role. Okay. Because the doctor may see the patient once. And then, for example, either the patient may be able to come to the clinic, or you may be doing home visit and seeing the patient at home. So the nursing team has a very important role. So assessment is something has to be learned very well and understood also properly, so that both for assessment, diagnosis, treatment, and outcome, whether whatever treatment you're giving, is it beneficial? Sometimes you give all the time, you give, it may not work too sometimes. If it doesn't work, that shows you have to go back and reassess again. So this assessment is very, very important. So this slide, I'm just telling only to give you the importance of assessment and why is it that you all need to know about assessment, so that you diagnose, treat, and also have a best outcome. So if outcome is not there, then you'll go back and reassess. And so you will even get to the diagnosis properly and management also. Next slide. Next, we'll see how are we going to assess. So basically, when someone comes in pain, these are the things you would generally ask. For this, we also follow a mnemonic, PQRST. I think this is for many things in medicine. We have something like these mnemonics. Mainly why we use them, for us to remember and not miss anything. So generally, when someone comes in pain, you will ask what are all given in this slide. Where is your pain? What is the type of pain? How long you're having the pain? Aggravating, relieving? Does it affect your day-to-day life? Does it affect your sleep? So this only is given by the PQRST. P means what are the provoking factors? Exactly. What is aggravating or relieving? Provoking means what makes your pain worse. Then quality of pain. Then radiating factors. Does the pain stay in one place or go anywhere else? Then next is site of pain, and that is the S where it stands. And then time or duration, how long you've had the pain. So basically all what is given here is what, and then on top of that, I would say you have to add at least few more things. One is the pain affecting your normal routine? Are you able to do all your day-to-day activities? Next, is the pain affecting your sleep? Last, but very, very important, is the pain affecting your mood and personality? For this, I'll give a simple example. Generally, when someone has pain for more than its normal duration, when the pain becomes chronic, either the patient themselves or the family will tell you. For example, if someone was a very calm, quiet person, they'll say he is not at all what he was before. He is now getting angry for everything and anything. And he snaps at people. He is not even having patience to answer. That could be one type of response. Or it could be the other way around. Someone who was very happy, jovial, cracking jokes, everything, they'll say, no, he's not at all himself. He doesn't even open his mouth now. So the impact of the pain on their personality does happen. And all these things you will see as you start seeing more and more patients. So all what I'm telling will make sense when you see more patients. So just you might think it is only pain. So these now, from all what I have said, you will this if you connect this to the definition. So that is why they've said it is not only a sensory, it has emotional experience also. So that is what we say as total pain. It has a physical component, it has an emotional component. Okay, it can have other components also, which we'll see. So you have to make sure that you get all these information. So that is why assessment is so important. Next slide. We do have some tools which we will be seeing. So generally you have separate tools for acute pain and for chronic pain. We'll see diagrammatically also. Basically, you have a numerical rating scale. You have something called a dynamic pain assessment. Basically, dynamic pain assessment, sometimes some people may say they're okay when they are not doing anything. As soon as I start doing something, I am in severe pain. I will literally be crying. So that is what is dynamic pain assessment. And then for chronic pain, you have separate inventory tools and questionnaires. And there are also some specific questionnaires based on the disease. For example, diabetes, dementia, elderly. See, all these by name and numbers, plenty will be there. But what is important is what will work for you in your particular area is what you have to find out and do. You should have a tool. For example, you're having patients in a rural area, big questionnaire, nothing may make sense for them. So you tailor make your tool for your area and for your need. Okay, that is the important thing. In the next few slides, I will show you some things which everyone can use also. Next slide. See, this is something called as a body chart. Okay, because anyone and everyone can fill this chart. It has one which shows the front of the body and one which shows on the back. So if you ask your patient to fill this, where the pain is, which area it covers, and also you can ask them to shade different areas, like somewhere pain is very, very much, another area pain is less. So they can shade differently and show you their intensity of pain. And first you have one done on your day one. And as I was telling, assess, reassess. You start some management and 4 weeks or 2 weeks, 4 weeks down the line, you see them. When they come back, they can refill on the same chart with a different color, which can give you an indication whether your treatment is beneficial or not. So one chart itself can be used properly, and simple and best, which will help you and give you maximum information, is what you have to use. Okay, next slide, please. These are you have number, facial, and then below the number, see, you have mild, moderate, also, because all of us are not the same. Okay, some people want to express. Generally, we ask if 0 is no pain, 10 is maximum pain, 10. But sometimes they may say, no, my pain is mild. Never mind. So see, that's why they've given mild means you can take it as 0 to 2, tolerable, then distressing, very intense, severe pain, 9 and 10, 8 to 10. So in this itself, you've got all components. So whatever type of expression the patient gives you, you can correlate and make use of it. Next slide. Next, coming to cancer pain. Cancer pain, no major impact has been the amount of pain that patients experience when they are having cancer. And WHO did make a guideline in 1986, but still they are not able to achieve the maximum benefit of easing that pain. So they say very many reasons are there, but of late, what is the common reason given is now many countries have the appropriate medicine in the country or in the place. but that being delivered to the patient is where the problem is happening. That is why we are also trying to make sure more people are trained all over India, so that now in India, availability of morphine is not a big challenge. Delivering it to the patient, wherever the patient is the challenge. We are trying to overcome that challenge also by training as many people as possible, having the availability, and then making sure that the medicine reaches the person who needs it and can get the benefit of it. Okay, next slide. So what is the difference in cancer pain compared to other pain? So this is an Edmonton assessment tool, which is said, if you see, it has got many components in it. Pain is not the only thing, because when someone is in cancer, having cancer pain, all the other factors, for example, they may have loss of weight, loss of appetite leading to loss of weight. So that makes them weak. So their well-being is affected. Why? Because they can't eat and they are weak and frail. They have low mood. And then all of this can be caused because of nausea. As I said, either the disease proper or the radiation, chemotherapy, anything, all can have so many symptoms. So all of these symptoms are interrelated. So you have to make sure that you give importance to all of these also. And the first and last one, pain and shortness of breath, are the most common troublesome symptoms. But underlying between pain and breathlessness, you've got the rest. All of them are equally important. So you have to give importance to all and try to manage all of them. For example, just food, loss of appetite and weight. You can ask the patient and family, give explanation to both patient and the carer why it is happening, how can it be tackled, by giving small frequent meals. So by doing that, you're satisfying the patient and the carer. The carer also wants to look after, but the way they want the patient to eat, the patient cannot eat. So these all awareness, giving them information, giving them solutions, how to manage. By doing all that, their well-being can be improved, their depression can be taken away. So all these are important. So that is why, for example, when you're going to do an assessment and management of pain in a cancer patient, you have to consider all these. That's why this is the recommended Edmonton assessment tool, which is it, putting everything into perspective so that you don't miss anything. Next slide. So this is an overall overview of what is to be known, so that you get an idea why is pain a complex thing, and then how can you assess it. And if you know to assess it, then we will go into the management in detail one. Thank you very much. And anyone, you can unmute and ask or type and go ahead with your queries.
So, Madam, chat box, one question.
Chat box.
Is one question, ma'am. Can you
Tell
please
the
give the correct
sequence of
sequence?
assessment of pain. Correct sequence.
Yeah. So, Madam, shall I?
You go ahead, Shiba.
Yeah. So thank you, ma'am, for the excellent session. Regarding the pain assessment, what we have to do is, you can keep it in mind, SDPQRST. SDPQRST. S is site. D is duration. P is provocating factor or palliative factors. Audio is clear or not, Sangeet?
Yes, yes,
Yes.
your
Okay.
voice is clear.
Okay. So, Q is quality of pain. So we have learned about different types of pain. So Q is quality of pain. R is radiation, whether the pain is radiating to one place to another. That is radiation. S is severity. So you can assess the severity through 0 to 10 scale. That is numerical pain rating scale or Wong-Baker Faces scale. So madam has shown that images during the session. So severity, the last letter is T. T is temporal factors. Is that pain is affecting their sleep, appetite, or daily activities? That all comes under in temporal factors. Does that make sense?
I exactly hope, is that clear? Who had asked the question? Jyoti Singh. Has that clarified Jyoti's? Yes, ma'am. Okay. We had used Morse Baker scale.
Any other questions?
There is something called as, is there something called as Morse Baker scale? I've had the other Wong-Baker.
Wong-Baker Faces scale.
that is what
Wong-Baker Faces pain scale.
That is what we are usually.
There are many pain scales.
Exactly.
Yeah.
See, there are, if you go and search, no, there
Visual
are
and
tools.
yeah.
There are tools like any number. That's why I said this numerical rating and the faces scale are the general things which are used internationally. Any part of the world you go, we use that. But as I said, no, you use something. If for example, it all depends on where you, to which area you're going to cater. If you're going to be in a very rural place where they won't know number, they won't know anything, use the body chart. See, you have to do something for your patient. There you go, say number and all, well, they may not know, but that doesn't mean we are not going to treat them. So you have to be aware of everything. See, always these names and things are needed when you're doing a course and things. But when you're practicing, you use this knowledge to practice and give benefit to your patient. Okay. So the names of scales and things, many things are there. And you should know what is essential. The basically numerical rating scale, Wong-Baker face scale, and then as we said, this assessment also. Now Shiba said that SDPQ, RSTP. Basically, all what is mentioned is there in that. Why we are telling all this in the morning? So that you don't miss anything. That is the main reason for it. Okay. So anything.
So
For what is the scale for patient unconscious?
yeah.
There are many things, as I said, that and all depends on what is used in your ICU. As I
And
said,
also, their knowledge level, no? So
exactly.
they are understand the 10 to 0 to 10 scale, then you can say that. Or otherwise, you can say rupees. 1 rupees less, no? 10 rupees big. So the normal persons can able to understand it.
Yes, that's what they have mentioned there. And someone has mentioned as some CPOT scale. That and all will depend exactly as Shiba said, no? It depends on the intensive care unit, what they use. So basic, as I said, just vitals. Vitals, and then each patient assessment, no? On the basis will be, and then that will be based on your setup.
Madam, one more question. Can you explain pathophysiology?
Pathophysiology again? No problem. We can. Okay. Basically, go back to that slide. So it is simple. So one thing, pathophysiology, what you need to understand is, it is not very simple as we think. From point A to point B, it will respond only in one way. So if it was like that, you will not have something called as a chronic pain and complex phenomenon at all. That is why the definition also is given like that. So what is said is, it is a neuroplasticity. What is neuroplasticity or exhibiting plasticity? That means it doesn't have a fixed path alone. It can, why it is not having only a fixed path? Because of the other mechanisms that we saw. It can have ectopic firing. It can increase the response. So, you're all aware of ectopic in cardiac system? Like normally we have, I will just give an insight on that. Normally, if you take, how does our heartbeat arise? You have the SA node, and then you have the AV node. And then from there, you have the Purkinje fiber. So for example, for cardiac conduction of our heartbeat, there is one fixed pathway. But always it doesn't. We have something called as ectopic beat, ventricular ectopic. So like that, there are fixed pathways and fixed places where it should fire. But there can be an abnormal site, and it can also start heartbeat. That similar mechanism can happen in the nervous system also. Go back to that picture, no? I think third slide, and give me the,
This is from
yes, leave it there and give me. See, for example, where is my, I can't. I can't do it.
in the man. Yeah, periphery now.
Now I can see, I can, thank you. That's itself. See, you can see my marker moving now. So basically, you have this pathway which goes from the side to the brain. So like that, at all these points, at the periphery, where here you can have increased chemical mediators. So initially, when the pain started, it would have started as though it, common example is back pain, okay? Some simple injury, okay? One small, not even fall, it will be one twist. Many would have experienced. So one twist only happened. So that time some chemical were released, and nerve, instead of one position, it got twisted. So at that point of injury, more chemical mediators can happen. And then it was only a sensory stimulus. But in all our nervous system, if you are all aware of anatomy, you have motor, sensory, sympathetic, all go as a bundle. Okay, so when motor is stimulated, sensory also is beside, so that can also get stimulated. They all have the capacity called as plasticity. So all this much information about pain and things have been known in the last 50, 60 years only. Initially, so much was not known. And 1965 also, there is something called as gate control theory. I didn't want to add on more thing and confuse. So there is something called as gate control theory. That also enlightened so much information on pain. So basically, to say that there is a fixed pathway, but there can have a collateral. It can take this pathway, it can take additional pathways, it can stimulate the adjacent sympathetic which is there. And for example, it had some intensity, like 5 chemical mediators only started off, but that 5 can become 50. So the pain intensity will, all these are the plasticity. These are the modulation or modification. So, and another example, what I said is amplification. So that is what is called as wind-up mechanism in this central nervous system. That is called as central sensitization. Basically, it increases or amplifies small pain to maximum pain by the chemical and the neuronal connections in the nervous system. So that is what is meant by not a hardwired, but it is a complex. And next thing, the emotional and sensory component, what we said, no? There are very many studies nowadays to say and prove when someone is in low mood, their pain is very high. I'll give a simple example. Take two people who have headache. Okay, one person is having headache and is by himself or herself in the house, no one to help, to do everything, no one to even give one cup of coffee. That person's headache, how will it be? Another person has headache but is with a group of 10 people in one party. How will the experience of same headache be? So there are reasons. It is just not factors. So the emotion, when someone is emotionally down, the chemical mediators are different. So many brain blood flow studies have been done recently, which match all these. So basically, the central nervous system, what is happening is not a simple mechanism. Multiple factors are there. That is why we are having something called as chronic pain. And only if you know all this, you will be able to put things to perspective when you see patients. You cannot generally say, for example, you have two patients, both have same disease, but have different intensity of pain. So you cannot and should not say, for example, same disease, one person may say pain score 5 by 5, 5 by 10. Another patient can tell a pain score of 10 by 10. So you can't say, no, you both have the same disease. He is having only 5 by 10. Your pain 10 by 10 is not true. It is false. We can never say that. Only if we understand this, we will not tell that. So because it has individual, that is why I mentioned about those 6 factors added on, because this pathophysiology is the reason why they added those 6 factors. Pain ladder, I think we will have that as a separate session, isn't it, Shiva?
Yes, ma'am.
You will have, as I told you in the beginning itself, you will have another 1 or 2 more sessions on pain. You will all become masters in pain. Don't worry. Explain ladder. Before that, there was a question. Sangeet, one second. Visual analog pain skills are suitable to measure pain. Yes. See, again, no, you go back to that slide where I had on, because that's why I put all in one slide. You have the visual analog, numerical, and the words also. Because see, better to have everything so that each one may express in different way. I think next slide. See, the picture one. See, you have visual, numerical, verbal explanation. Everything is given in this. Why I put all these things? Because each place, some places have just the faces, some place have the numbers. So you see, you have everything, put things into perspective. That is why even when I said no, someone says mind, okay, if they can't put a number, you have to document in a chart, put it as roughly between 0 to 3, something like that. So you take everything into perspective. Anything you want to add, Shiba, add on, and we'll scroll through the slide, the question, anything left on.
So because each institution's their own.
Correct. Exactly.
Usually in palliative care,
miss,
we
no?
prefer a numerical pain rating scale and a Wong-Baker Faces scale. But you can use whatever you have. But our aim is to understand the level of pain.
Correct. Because this is important for management. Only if you know this, see, you were all asking ladder. You learn this properly, then your management with the ladder will come handy. Okay? Because this assessment is what is going to help you in management.
Yeah. Exactly.
I just went through the questions. I think we have cleared. If we have missed anything, please do ask, or else we can go for the case presentation.
Yeah, ma'am. So, before moving on to the case presentation, I would like to highlight few things.
Yes.
Today's session. So, madam has covered a lot of points today. What is pain? What are the different types of pain? What is the pathophysiology of pain? And how will you assess pain? That all things madam has covered well. So, so for the nurses, I would like to tell you one thing is when a patient comes to you with pain, pain is, don't assume. Pain is a subjective experience. We need to believe the patient words. So that is one thing you have to keep it in mind always. When a patient comes to you with pain, you have to do the proper assessment. At the same time, we need to believe the patient words because pain is a subjective experience. Okay. So based on your assessment, you have to treat the patient. So you have to do the proper assessment. Always you have to keep the SDPQ or ST in your mind so that all things you can able to assess. You don't miss anything. So this is very, very important. Okay. We can move on to the case presentation. Swati sister will be presenting a patient's story. Swati, over to you.
Okay.
Hello.
Go
Good
ahead,
evening,
please.
ma'am,
Go
sir,
ahead.
and everybody. My name is Swati Manish Gowde. I am from HNCCI, Head and Neck Cancer Institute of India. And today is my pain management patient for cancer. Mr. Gopal Keshav, age is 66 years, male. The diagnosis is severe rectum, stage 4, with hypertension, with known case of hypertension and CVA. And the present complaint is bleeding per rectum, constipation since 3 days, and moderate pain in the lower abdomen and lower limb swelling. And the history of illness is he had a history of hypertension, history of alcohol, tobacco chewing since 30 years, decreased oral appetite since 2 months, weight loss, no history of piles and other history, hemorrhoids and all these things, no history of chemotherapy, radiation. And examination, patient is conscious, verbally oriented, and vitals are a temperature 97 Fahrenheit, pulse 80 beats per minute, respiration 20 beats per minute, blood pressure 118/72 mmHg, lower limb swelling is there, abdomen distended with it, and tumors present in both upper limbs. And treatment and significant investigation, normal investigation did here, UHG abdomen is done 16/11/2020, described as a hepatic lesion with the liver met, and the hemoglobin is 8.3, WBC is 10,800, creatinine 0.67 mg/dl, sodium 132 mmol, and the potassium 3.92, chloride 98.8, and the bilirubin total 4.56, and the direct bilirubin 2.5, and the indirect 2.05, and the GOT 297, GPT 62, protein 4.44, syrup albumin 1.94, globulin 2.5, alkaline phosphate 872. And the treatment we are giving the best supportive, best palliative care, and this supportive treatment, antibiotics, pain relief medication, anticoagulant medication, counseling patients and relatives, and respite admission for observation and the social reference. The psychosocial aspect is 66-year-old married man living with his wife, 61-year-old. 2 kids is there. One is a boy is unmarried, 27-year-old, is jobless, and one daughter is a 19-year-old who is studying in college. And they are staying in the Charles 15 one room only, own house. And he is depending on his small flower shop, no other income source from there. And he wants to meet his brother who is staying in town, in his village, and other relative also. And and he wants to taking blessing from hometown God. The medication treatment is injection vitamin K 1 ampule, IM once a day for 3 days, and tablet Rifagar 550 mg once twice a day, tablet Trenexa 500 mg once twice a day, and SOS
and tablet dolo 650 mg, 1 TDS, tablet Tapal 25 mg 1 twice a day, and SOS, syrup Dupalex 15 ml HS, and Lonit 150 mg 1 twice a day. The main concern is the first is the bleeding for rectum and the foul smelling, pain, loss of appetite, social isolation, and the sleep pattern is changes because of pain and the bleeding, the financial issue, spiritual issue, anxiety, depression, and sadness. The summary is a 66-year-old man having a severe rectum stage 4 with bleeding for rectum, pain in the lower abdomen, and known case of hypertension with severe spiritual issue and the financial issues there. The discussion point, ma'am, is what will be done to prevent the bleeding first, and second is what can we do for satisfy the patient's family needs, and third is how we will fulfill the spiritual need of the patient.
Thank you, Sister Swati, for the excellent patient story. Anybody need any more clarification regarding this patient story? Please ask her. Otherwise, we can move on to the discussion points. I hope this presentation is clear to everyone. We can move on to the discussion points. So we all discuss together and help Sister Swati. So Sister Swati came with a patient
Yes, ma'am.
story, and there are many discussion points.
Yes, ma'am.
Basically, like she
Madam.
did everything, like the whole palliative care discussion can be done with this case because she's brought in everything very good. So always positives first. First thing, one appreciation for bringing up a case because all of you have to do it. So don't think this. Can I ask Swati? Swati, isn't it? Name? Do
Yes,
you
ma'am.
work? Do you work in a? Do you have palliative care in the place where you're working, or are you working
Yes,
in
they are
palliative care?
started. Yes, they started now. Head and Neck Cancer Institution. They are starting now.
And the cancer institute.
New hospital is there. They started from May.
From May. Very good. So that's a nice thing. So as I said, nice of you to bring up a case, and that's what. See, either many of you may be practicing in it. It could be a cancer patient or non-cancer patient. Also, you will see through the sessions. You will see that palliative care is not only for. See, in the first session, what did I say about defining palliative care? Is for both cancer and non-cancer. So all of you can bring up cases and try to keep on bringing because this is what will bring up discussion. So if you see the concern point of view, Shiba, I'll just go through touching some and then we can go because all concerns, we have got, today we will stay mainly on pain and other elements which can also, you saw provoking and factors which affect the mood and things, no? So you have got things like that in this case. So we will pick up those and discuss for today. And the rest can be, as I said, the whole palliative care discussion can go on with this. So main thing, in that she mentioned the third point is pain. So you did mention lower abdominal pain. So from what we have seen today, what is that you'll do? First, there are a few things that you have to assess. How was his pain? Can you throw some more light, more assessment factors or information on his pain? Like, was it scored or was it given? What was the intensity of pain? And did it affect his sleep? And already he had many other social and if you could give some more information, if you had assessed. If not, also is fine. If you had assessed, how was his pain?
His pain is around 6 to 7 by 10. and then his pain is so just like hammering pain. Sorry, hammering pain. Hammering pain.
Anchoring pain.
Hammering,
Oh.
just like, and this is aggravated when he is walking or turning on bed.
When he was?
He is turning on bed or something is doing, that time his
So
pain is more
activity.
increased.
So activity was increasing the pain and the score was between 6 and 7. Is that right?
Yes, ma'am.
Okay. See, that is what. So from today's point of view, if you see, those are, how will you assess? And then was his sleep affected?
Yes, ma'am. Yes, ma'am. Sleep is affected.
See, so basically from what we have seen in assessment today, like you saw the site of pain, duration of pain, and then intensity of pain we saw, and then she's seen the provoking factors, and she did mention that activity was aggravating the pain, and was it affecting his routine? Yes, it was affecting his sleep. So this is what is important. Assessment of pain is very important so that you consider everything. Okay. And then you go on to dealing with each one. So, like, based on this, no, when you have your next sessions, you will know if it is the score is 6 and 7, it will be moderate pain. So, how will you manage moderate pain? So, in your next sessions, you will have the pain ladder and management, which will be considered then. Here, another few things what I wanted to highlight were, see, he has financial, spiritual, all issues are the anxiety, depression. So from that point of view, you will have to keep in mind total pain. I did mention that, see, that you have sensory, emotional component. So there is something called as total pain, which has physical pain, psychological pain, financial and psychosocial and spiritual. So he has all components. He is the breadwinner. So that itself is a big issue. And then see, she did mention he wants to go to his hometown and get the blessing of his hometown God. That is the spiritual element. So each one you can try to, and then the financial and psychosocial elements, you have to try to manage. All that you will see through the sessions. As I said, no, you will have separate sessions for all of these. So, but good that you have brought up everything. So you should see this person as a whole. If you just give medication for him alone, will all the other elements be covered? No. So only if everything is covered, his pain score will come down.
Yes.
So that is what to be kept in mind. And there were 2 questions in the chat box which I saw, which I thought I will answer also. The how frequent reassessment to be done. That is based on the way how you're treating. That again will be based on the medical management. So at least initially once in a week or once in 2 weeks you see initially. And once their pain is well controlled, then you can see them once in 4 weeks. That is one of the answer. And then for bleeding, they have mentioned, yes, tranexamic acid can be used. And what? Antihypertensives to control hypertension, basic dressing. Yes, all this to be taught to the family and all. What they've replied in the chat box can be given. And the same thing someone has written also about giving pain medications, seeing the response and assessing. Shiva, you add on anything else you want to add on, and then maybe go to the next slide.
So, regarding the pain review, pain assessment review. So when the patient is in the hospital, if you give some painkillers, after 1 hour, you have to reassess whether that medication is helpful or not. So that is very, very important. You have to go there and talk to the patient and assess the pain score. So, or if you give a painkiller, pain analgesics to the patient and the patient wants to go home, then what we do here is on the next day, we will make a phone call and assess through phone. If that medication is helpful or not. So
Yes.
you can do the telephonic review or you can do the in-person review.
Exactly. I didn't want to add on more stuff because it all depends on what medicine you're giving. And what, as Sister Sheba said, inpatient means the patient is under your nose. So you can assess. Even if you're sending the patient home, you have to call them. Okay? Because see, our main aim here is to ease the pain. So that is why I said until pain control is obtained, you have to keep in touch. Telephone review is very commonly done, not only now, nearly few years, 5-10 years of all our practices. Communication option is there. So you can ask the patient to call you and update how they are in 12 to 24 hours. And then based on that, they're very okay, happy with it, continue. Or do some alteration, even if they have gone home, and do all that so that every day the relief is better and they are able to get to a stage where their pain is manageable, and then you can look at regular long-term reliefs.
So
have you clarified all? Does anyone has any other query?
Sister Swati, what
Yes,
about
ma'am.
patient physical status? That physical condition.
Physical status, physical condition, the patient is the pain and the bleeding from the rectum.
Okay. This patient is having a stage 4 cancer, but because this patient is having bleeding, no? So
Yes, yes.
yeah, and also this patient is on tranexamic acid, right?
What, ma'am?
Tranexamic acid.
Yes, 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 yes. Yes.
Yeah.
Tranix
So,
the tablet.
is that medication is helpful or not?
Because previously bleeding is 30 to 40 ml. The relative is telling like that. Not more. So doctor is started into tablet Tranexamic, and after
Okay.
observing.
So what is your plan?
My plan is for this we already stated bleeding not call again, and we already take care for this for bleeding. If bleeding continues, then we have to start injection also. Injection Tranexamic.
Thank you. So why I am asking this thing is, if the patient's physical status is okay, if the health is okay, then you have to think about the radiotherapy. So you can refer the patient to the oncologist. If there is a end of life care patient, you can try to relieve the symptoms. No, so you can communicate with the patient, communicate with the. You can talk to the relatives and make them understand well. And so, but if the patient's health status is okay, then you can think about the palliative radiotherapy. So that if you do the palliative radiotherapy, so that way we can able to the control bleeding. So better you can talk to the concerned doctor and think about the radiotherapy and refer the patient, if possible, refer the patient to the oncologist and take oncologist opinion too. Madam, what do you think?
Same thing. Like it all depends, no? If you said best supportive care. So if there is a possibility of palliative radiation, that will help with bleeding and pain. Okay, it all depends on the facilities that you have in your center. If a radiotherapy department is there, you refer them there because it will help both in bleeding and pain relief. So then if they get more relief, then maybe he can go to the village, see the God and come. So that will make him happier also. So like that, you have to see all things that we can do to deliver best palliative care. As you mentioned in your slide, no? That is what we want to give, best supportive care. So always palliative radiation can help with easing the symptoms and giving some relief and benefit also.
Yeah.
Especially if it is bleeding, no, it will ease or stop the bleeding also.
So definitely you can try many things like tablets. So you can think about systemic chemolytic agents, and also you can think about local application
Local.
also. Ethamslate local application and adrenaline also. SOC that you can what we use here is you take on 1 ampule of adrenaline and mix with 100 ml of saline, and that solution we soak with the dressing pad and choose out the excess water from the pad and insert the bleeding area, especially rectal bleeding, so that the bleeding we can stop. Then you can think about, as I mentioned earlier, you can think about that radiotherapy and all. So as ma'am Miss mentioned earlier, so our aim is to stop bleeding. If is there any way there, definitely you have to think about that. So, and the next discussion point is what can we do to satisfy patient and family? So how can we do it? How can we satisfy the patient and family? So from the day it's one itself, you learn palliative care is for patient and their family. Okay, so how we can anybody say we are respecting your comments also? Please unmute yourself and talk, or you can put your answers.
Yes, that's all. You can unmute and talk also.
So we all nurses, whatever you want, you can talk, no?
Ration provides, give some food for the family, yes.
Okay.
Because he's the breadwinner, yes. Or help for fees for that college, get some help from NGOs. Exactly. Very good. You are all coming to all the points which is needed. So getting financial support from NGOs or someone who is willing to help. Very good. That's what we also like. It should be an interactive session. All of you know everything. Help from NGO, yes.
Ma'am, collect the money from this thing and we can give it to
Group funding. Very good. Some job, encouraging something is there. They have typed. Son's job. Okay, some job for the son. Yes. That's a job for the son, fees for the daughter, occasional for the training, education support. Exactly, very good. You see all the social needs.
Yeah.
So,
exactly. Yeah, thank you for your answers. And one more thing I would like to highlight here is, so there are many problems because we don't know what exactly they want. You have to spend time with the patient, possible individual. Do a family meeting and elicit their emotions, understand their things, because they have their own that wishes and all. So you have to understand their problems first, and based on their problem, try to solve. So sometimes your treatment is not that they are not quite happy. That type of thinking will be inside their mind all the time. So you better during the treatment have to find out the time and talk to them and understand their that emotions, and you have to identify whether the treatment is this treatment is happy or not. Otherwise, you have to give a good clarification. so that you can able to make a good rapport with the patient and the family, so that we can able to care the patient as much as we can. Madam, any
Exactly. No, that's what I was about to say. Based on if you have social worker, psychologist team, well and good. Okay, they can do sessions because all these will not happen in one meeting. That's what Sister Shiba was also trying to say. You have to give some time. So if you have a separate team, psychology, social worker, well and good. Or you have to do devote some time, find and or refer them to somewhere based on that. Then you have get to know a bit more, because as we were telling, no, just giving medicine alone may not bring your score from 7 to 2 many times, because that person's main worry may be, oh my God, I am worried my family will not get food next month. So he may even sometimes take tablet, not take tablet, water, because their main concern is something else. So that is why we say you have to see and look after the patient in total. Okay, that is where first, by having more, first time itself, everyone will not open up. Even we will not open up. Okay, we have to gain confidence. So that is what gaining rapport, gaining confidence, all that is important in total. And then move forward little by little, and then everything. Once they get confidence that you're going to help them in all ways, even this medicine will work, he will be happier, they will open up and tell you. And then you can deal with both patient and family. And then last, how we will fulfill spiritual needs also. During the conversation, we said his main wish was to go to his town god. So once you solve all this, you give him an option. Okay, we'll make some arrangement for you to go there. That will maybe be the best for him. He'll say, if you can do that, I'll be so happy. Something like that. So everything you are finding out and dealing with each issue there is what will be helped. And someone had asked in the chat box about constipation. You will have a session entirely on constipation and bowel issues. So that will be taken care. Is that right, Shiva?
Yes, ma'am.
I saw that in the box. So I thought need not leave anyone in query. That also can be.
We are focusing on pain only. Pain.
Exactly.
So, yeah. So I think this patient story discussion points is covered.
Yeah.
Sister Swati, anything you want to ask? Need any more clarification or anything? Please unmute yourself and talk.
No, ma'am. Thank you.
Very good. As long and that nice. It is better if all of you bring up some case. See, from this, what you have to learn is by bringing up cases, many points will be discussed. All of you can get more clarifications. Not only one person, everyone will put in their ideas and views, and it will be good for everyone. So please try to do that all the time.
Yes. So, and one more thing I want to tell you is go back to the your patient and ask. You can do the pain assessment again. The patient is on tramadol. I understand that the patient is on tramadol and paracetamol. You have to find out the patient is getting good pain relief with these medications or not. So, so that we can able to understand, no, your medication is helpful to the patient or not. So that our aim is to live that their quality improvement, no? So that's that one thing you have to do it. And as ma'am said, total pain concept. So if there is a psychosocial issues there, the physical distress will increase. So wherever the psychosocial issues are like this patient financial the stress is there, spiritual concerns there, emotional tensions there. So there are so many psychosocial issues. Kind of psychosocial issues there, their physical distress definitely will increase. We have to give a proper attention to the 4 aspects: physical, emotional, social, and spiritual aspects. So that is total pain. If you are able to give a attention to the 4 aspects, definitely we can able to improve the quality of life of the patient and their family. Okay, and also we can able to satisfy the patient family also. If you look into the 4 aspects, definitely they are the family members are observing, no? So you are covering the physical aspect, not only the physical aspects, you are covering the emotional aspects, spiritual aspects, and social aspects. You are trying to fulfill their wishes, no? So definitely the family will feel happy after this. Okay. Time up. I think we can wind up the session. Madam,
Yes,
can
yes,
we?
yes, yes. I think we are good. Very glad that you brought up a case and we could have a nice discussion.
Okay. Thank you, ma'am, for the excellent presentation. Thank you, Sister Swati, for the excellent patient story presentation. Thank you all for your contributions. See you in the next
Thank
session.
you, Manan.
Thank you. Bye-bye.
Thank you, Shiva ma'am, for the facilitation. Thank you, Radha ma'am.
Thank you, madam.
So let's see you in the next session. Thank you.